everyone, and welcome to our lesson on triage in the emergency department. Today, we're going to discuss what happens when a patient first comes through the door of your ED. So, we've probably heard the line, nurses are the front line of healthcare. Well, nowhere is it really more of a literal translation than in ED triage. The nurse is truly the first person that a patient will see when they walk through that door. So, in case you were wondering where modern medical triage started, it was the French. Specifically, a surgeon named Dr. Larry, who it was during the Napoleonic Wars, he treated the wounded according to what he saw. He saw how badly they were injured and how quickly they needed treatment, and that was what guided this process. Now, don't worry, I'm not going to test you on this, but, every once in a while, it's nice to know where things do actually come from. Moving on. So, triage is a process. The first step is a visual or across-the-room assessment, and this is what we do when the patient walks through the door, like literally walks through the door. The second step is the triage interview, and that's where we actually talk to the person. And then the third step is to collect vital signs and perform a quick objective assessment. So let's dive a little deeper into this. So your patient just came through the door. What happens? Well, you probably look up or you hear them screaming as they walk in. Either way, at that moment, triage has started. That across-the-room assessment is just that. When you look up, what do you see? At this point, really, you can make your triage decision. If there's a knife sticking out of somebody's chest, or if they're holding their severed left arm in their right hand, well, I'm going to go right in. Probably a level 1. If someone comes in and says their dad's having a stroke and you can see the guy's drooling on himself and the entire left side of his face is drooping, boom, right in. And yes, I did put smell up here. And I can attest to this one. You see, a young woman was once brought into the ED, semi-conscious, GCS of 12, Glasgow coma of 12. And that alone means we could triage her like a 3 at the least, but most likely a 2 or a 1. But as she rolled in, we smelled the strongest odor of gas we had ever smelled. It was on her clothes, her hair. We didn't even have to get that close. In an instant, before she was even through the doors, this changed from a fairly routine case for us to a full-blown level 1 hazmat incident, complete with like the Nomex suits and full decontamination. Turns out she was using a space heater that was leaking kerosene into her apartment, and she'd been inhaling it most of the day. So, let's say your next patient is not a kerosene-snorting stabbing victim. And for most of our patients, we can get to the second step in triage, which is the triage interview. This is usually that first interaction a person has with the ED, and it can really set the tone for the whole visit. Triage nurses not only have to be detectives and researchers, but counselors and social workers too. Listening to a patient's story, getting the important details, and really putting aside all that extra stuff they're going to tell us, and then determining the course of treatment options, all happens in minutes in that triage booth. The nurse is going to do their best to get a history, and one of the ways to do that is to use the sample mnemonic. It's signs and symptoms, allergies, meds, past pertinent medical history, last oral intake, or last meal eaten, we use that too. It's easy to say that because people think oral intake and they get weird. And then the events leading up to what happened. If you can get that, you got a pretty good history going. And once we have an acceptable history and realize it may not be the best because, we're kind of pressed for time here in triage, we're going to move on to the objective assessments. First, we try to get a full set of vitals. The patient's vital signs can actually change their triage level, which we're going to get into. And then we try to make some objective physical assessments. We're not doing a full head to toe here in the triage booth, but if they say they cut their arm, you want to look at the wound and kind of document what you see. So, triage severity rating. The triage severity rating is the level we give each patient to determine the urgency in which they need to be seen. Now, in most hospitals, many of us are using a 5-level triage system based on the Emergency Severity Index, or ESI. The ESI is a combination of 2 things. It's the severity of the situation, or in other words, the potential for life, limb, or organ threat, and also the predicted resource consumption, which we'll talk about on the next slide, basically how many resources we're going to need. So the levels go from 5 to 1, 5 being the most severe. They go from 1, most severe, to 5, not severe at all. 1, bad, 5, I'm not going to say good, but not as bad. So level 1 needs immediate treatment. Anyone intubated? 1. No pulse? He's a 1. Severe trauma? He's a 1. In some facilities, if a code stroke is called from triage, usually a 1. So level 2 is just behind that. Are they disoriented, acutely lethargic, severe pain, respiratory distress, some of your less severe traumas, or vital signs in the danger zone? They need to be a level 2. And as far as the vitals go, we consider an adult in the danger zone if they have the heart rate over above 100, respirations above 20, and an O2 sat less than 92%, and that's with no comorbidities. If you have a 92% with a COPD, you got to take that into account. So level 3 is when we start worrying about resources a little more. If we anticipate they're going to need several resources, there are 3. Like a young guy with flank pain and no history of trauma, we might be thinking kidney stone. So we know they're going to need IV meds, labs, and a CT, which would probably make them a 3. Level 4 is going to need 1 resource usually. An asthmatic who needs a neb treatment, that could be a 4. A guy who thinks he may have broken his finger needs an x-ray, that's a 4. A mom who cut herself on her hand with a kitchen knife and may need a few stitches, that could be a 4. They're all using 1 resource. So at level 5, I wrote, please have a seat, and that's kind of what it is. This is everything else, point-of-care testing like a pregnancy test or a flu swab, wound check, stitch removal, script refills. These are all 5s. These patients, unfortunately, are probably going to wait. You see, the recent explosion of urgent care centers is helping to kind of alleviate some of this, but they're still coming to us. And by the way, if you're wondering if you can tell a patient to just go to an urgent care center if you know the wait's going to be long, I want you to check out our lesson on EMTALA and legality in the ED. And in case you're wondering, you can't do that. Yeah. So we talked a little bit about resources. What is a resource and what is not? Resources they're considered items or materials that if we use them too much, it's going to put a strain on the ED. Things like labs, radiology, and with radiology, I include everything: X-rays, CT, MRI, ultrasound, all radiology. IV fluids, IV, IM, or nebulized meds, any call to specialists, and certain procedures. A lac repair is 1 resource. A lac repair with X-rays and a call to ortho is actually 3 resources. So what's not a resource? Well, we talked about some of them, that point-of-care testing like pregnancy tests and flu swabs, finger sticks, oral meds or script refills, some simple wound care, basic sprain and strain care like crutches or splints. That's all not considered resources. Much of triage is based on how we determine the resources we're going to use. So I want to talk a quick second about START triage, which is simple triage and rapid assessment. Now, this is a little different, and this is what we use in disasters or mass casualty incidents, basically when everything starts to go sideways. At this point, we're going to pull out these special triage tags, like our one right here. They look like this. Some are different, but they all generally have a color coding part to them. The idea with START triage is that we're here to do the greatest good for the greatest number of people. We need to accept the fact that in these situations, we're not going to save everyone. And if we focus all our resources on the one patient who's on the edge of death, we're going to be limiting the work we can do for all the other victims. So the START process involves making a rapid assessment. We're talking less than a minute of every patient in the event. And then when we determine which of the 4 triage categories they fit into, and we're going to visually identify them with color coding, like the colors you see down here. So let's go through them. So green is basically walking wounded. All right. These are people with minor injuries. Now, I've been in incidents where the medical commander is going to actually say, loud enough for everyone to hear, if you can hear me and you can stand and walk, I need you to come over to this area and see the nurse. Anyone who can do that is considered a green tag until they're proven otherwise. Then we get into yellow tags or delayed treatment. These patients need to be transported, but they can wait. They probably have some significant injuries, but we don't think they're going to get worse over 24 hours. Simple fractures, lacerations when we've controlled the bleeding, stable vitals, people who are alert and oriented, things like that. Red tag or immediate. So these are the patients, they need help. We got to move them. They need that rapid treatment and transport. And we know we can help them if we can only get them to some sort of advanced treatment within about an hour. Compromises to airway, breathing, and circulation all fall in this category. Things like bad fractures, head injuries, but who are conscious and conscious but altered, respiratory distress, burns. These are all red tags. And then we get into the one that nobody ever wants to accept, and that's the black tag, or expectant is another way to put it. No one ever wants to use these, but it's necessary. These victims are unlikely to survive due to their injuries or the level of care. So things like no pulse, black tag. Open head wound with like visible brain matter and they're unresponsive, black tag. Multiple gunshots and they're unresponsive, black tag. Understand, we don't do CPR during start triage. To code someone in a situation like this would deny all the other patients that could benefit from our help. It's not pretty, and I hope none of you ever have to make this call, but it is a reality of the profession and a little bit of the time we live in. Okay, guys, so triage is all about judgment. The experienced nurse can make these judgments in minutes and set the tone for all the care the patient's going to receive. We want to be careful about what we do in triage and how we treat all our patients. We really can't turn anyone away, and frankly, we really shouldn't. And of course, triage is about prioritization. Who needs to be seen? Who can wait? Couple of key points. Like I said, triage starts when they walk in the door, guys. We're first going to use our senses to make our assessments. Look, listen, smell, make some decisions. Who's the worst? The stroke's going to get seen before the abdominal pain, and the abdominal pain is going to get seen before the flu patient. I know the patients don't want to hear that, but the sickest patients go in first. You want to know all the resources that your department has and how we're going to use them. That's going to help you during triage. And of course, with start triage, while we never want to use it, we need to know the basics of start triage. And I suggest if you ever know of a disaster drill being performed either in your community or by your facility, get yourself involved in it. They're a really good tool to learn. All right, so once again, guys, thanks so much for tuning in. I really appreciate it. Please check out all our other lectures in our emergency medicine series here on nrsng.com. And as always, happy nursing.